first big supporters of Frank's initiative in the healthcare workforce roundtable. So we're here all to share our hopes and aspirations to get our community on the up there in the scale of ranking, but more important, wellness. And I have to confess, I learned a word the other day called incel, INCEL. You'll have to look it up if, for those that don't know it, but incel refers to the internet cell of far of deranged groups, whether it's the far right, the far left, or any kind. And some of that has also contributed, not just the pandemic, but the incel social media. And while we put up the Nashville shooter, I remember very well, I brought in the business industry political action support for Gabby Giffords, and they got her elected. And I remember well, it was a deranged person that shot her. So we need to get our community well. Now, I'll also mention that Fort Tucson was our first financial supporter because we sort of have a bunch of Harvard guys here, Eagles and me. The Harvard Flourishing Project was adopted by Fort Tucson to work with the Amphi neighborhood, which is a neighborhood I know well. Two of my granddaughters went to Satori School there. And I think that's all I have to say. Let's kick it off. Frank, it's all yours.
Well, thank you, Conrad. First of all, I want to thank Eagles and Conrad for putting this together. It truly is it certainly is a crisis and in so many ways, and to have I see 50 participants on this call, so that's amazing. So I'm looking forward to the discussion box. So let's dive right in. All right. So my first question, it's more of a personal touch question. You know, obviously with the COVID pandemic, it created, among other things, many things, a need to address our own emotional well-being. Yet we are all on different journeys, as we know. What have you done personally to take care of yourself? And what have you seen with whether it's your clients, your students, your colleagues? Would really love to kind of hear for yourself and for the people you work with or serve.
Well, okay, Frank, I'll go ahead and go. First thing, I think it's really important to acknowledge that this is the first day of spring training. And, you know, I heard today on the way in that they're changing basketball up so it's much faster. So, because people don't want to sit around and watch batters and pitchers stare at each other. And people probably don't want to listen too much to all of us carry on too much, but I'll carry on a little. So certainly in the aging space, I'm the CEO, as you mentioned, of Pima Council on Aging. We're the area agency on aging here in Pima County. For more than 50 years, we've been primarily about trying to figure out how to help older adults and then actually helping older adults stay in their homes as long as possible. And we know that somewhere north of 75 or 80% of older adults tell us they want to age in place in their chosen residence. But in order to do that, folks are going to need help. During the pandemic, I think, my mental health issues around pandemic, or my responses, were working and trying to completely retool, like all of us, I think, a service delivery system and a community-based organization to be able to respond. But one of the things that we know that we talk a lot about in the aging space is isolation. And actually isolation, and I would say its driver, I just have recently started hearing people talk about social drivers of health as opposed to determinants, probably a little better word, the driver of loneliness. And we know based on AARP research that somewhere in the vicinity of 25% of older adults were isolated and lonely before the pandemic, and those numbers certainly significantly increased during the pandemic. And so part of our issue during the pandemic was really trying to figure out how to help people reduce their loneliness. Again, people can live isolated lives and not have it negatively impact their health. But loneliness certainly impacts their health. And we have heard, based on research out of the University of Utah, that loneliness has the negative health impact of smoking something like 17 or 18 cigarettes a day. So that's probably enough for me.
Thank you, Mark.
Frank, I can go next on this.
Absolutely.
From a personal standpoint, and I share what Mark said. What I needed to do for myself was to keep busy, and I had been looking at what my retirement plans were going to be and such. And then in the early stages of COVID, when I'm pretty much sitting in a big house all by myself, I came to the realization that I'm not going to retire. I hate it. I hated sitting at home. There wasn't enough to keep me busy. We're in the midst of a crisis. My whole career has been managing crisis to crisis to crisis. So I started coming to work, and that was actually the best thing for me, was keeping busy, coming to work, and feeling like I was actually contributing something. From a staffing standpoint, I was pretty worried because behavioral health is a very personal thing. And even though we can provide services by phone, through video conferencing, it's not as effective as face-to-face. It's hard to establish those relationships. It's hard to get a sense of what you're dealing with. We were fortunate that Access allowed us to bill for video appointments and phone appointments at the level that we were billing for face-to-face. So from a financial standpoint, that helped the organization. But what we did find was we lost a lot of employees, particularly younger female employees who had school-age children, because somebody had to be home with the kids because the schools were closed. And a lot of those folks never came back. And that's something we continue to struggle with. It also got us to get a little creative with our benefit packages and what we offer and such. But, when you go through this, I wasn't so worried about myself. I saw this as a time for me to actually earn my money. I was concerned about our staff and how they were handling it. And I was concerned about how we were going to continue to provide services to the people who needed it. And then I was also extremely concerned about the financial health of the organization, because we could have easily gone upside down over that period of time.
Thank you, Dan.
I'll go next.
Thank you, Tomas.
Yeah, just building on Dan and Mark's comments. Personally, like everyone else, is a very challenging time trying to lead and provide support to your teams and the community at a time where everyone was stressed out, scared, so I had to really focus on my spiritual health and my physical health. I spent a lot of time walking around, hiking, trying to be out in the environment, taking advantage of open spaces and then just deepening my relationships with close friends and colleagues and families, and going back to the old school telephone calls, where Zoom was not or FaceTime was not available. So just really trying to maintain that human connection with people. And so one of the things that really helped, though, too, during this crisis, and what happens anytime you're in a crisis, whether it's a mental health crisis or any type of crisis in your life or in the community, in your organization, is that you come together with others around you because you're not alone. And so we decided as an organization at Equality Health, we were going to step in the gap and take a meet me where I am approach and reach out to Black and Hispanic communities, Native American communities that were being devastated by this pandemic, higher rates of hospitalization, deaths, job loss, home, becoming homeless and food insecurity, all kinds of issues. So we just came together with a bunch of public-private partners and went out into the community and started creating access, fair and equitable access to testing, vaccine, medical care, social support. And people were really appreciative of that because they felt like somebody cared about them. And it was great. It was very hopeful and energizing to come alongside other partners to be in the trenches battling this pandemic and doing everything we can to ensure the safety of the public and helping families and seniors get the support that they needed to protect themselves from this virus. So that was very energizing. In a sense, it really kind of caused you to reflect on what's most important in life and what is your purpose in life. And so for me, there was no better reason than to be out in the community in the trenches alongside my colleagues and friends battling this pandemic and serving people in communities. And people were very grateful for that support.
Well, I guess I'll be the caboose.
Go ahead, Beth.
So my perspective is a bit different because we were the educators that had to keep our young people learning. And so you talk about a whole adjustment of going from real world classroom to Google Meet to Zoom to, platforms that we really hadn't been using. And so the learning curve for all individuals involved was huge. And so March of 2019, when we went on spring break, that was the last time we walked in our classrooms until August of we went 19, 20, so it was 21. So we had been disengaged for so long that no one knew how to effectively communicate, how to even teach anymore. Our students were socially and emotionally disengaged. They didn't know how to learn. And I think, I always say, I can teach anybody to do a skill. You really can, but you can't teach someone that emotional component, that social component that is so important in our young people. So to this day, we are still struggling in the classrooms. Our students are about 3 to 4 years behind. And so when we're working with our juniors and seniors in our healthcare pathways, which are very challenging, they're getting regulatory certification. It becomes a challenge to meet them where they're at by also meeting our regulatory agency to what the standard is. And in healthcare, anyone that has practiced, safety and patient care is number one. And so during the pandemic, if you guys, those of you who don't know me, but I'm a very codependent individual. I am a nurse. I worry about everybody. I try to take care of everybody. I have a huge heart, and that was my job during the pandemic, was reaching out, being the conduit for my team, retaining my team. The loss of educators has been immense. And we're very special educators because most of us come from industry. So our first love or job comes out of healthcare, if it be at a nurse, a medical assistant. We have physicians teaching in our program. And then secondary is becoming an educator. So then I had several new employees that were trying to meet the student via Zoom, never been a teacher, the students, not wanting to be on Zoom. It was a very traumatic time for all. And I think we're still recovering. Me personally, I'm a huge health advocate. I work out every day. I take care of myself. I have too many people that count on me. So I have to make sure that I'm well to be that strong person for others. And so that is what I preach to my staff. That is what I preach to my students. It is about keeping your soul and keeping it strong and healthy. And so we continue the struggle. The COVID fatigue continues, and we hope that next year will be a better year. This year's been very traumatic as well, because of such loss in education with our young people. The struggle is real, people, right? So thank you.
Thank you, Beth. And Conrad, if you wanted to add anything as well in regards to how you've taken care of yourself in the emotional wellness space, and then any of the people that you work with or that you collaborate with.
Okay, well, I'll just comment that I'm 80 and I'm looking forward to the next day by day future of my life. And I found that I've been studying positive aging. And actually, the way we got started on this alliance was with Mindy Fain and the Whole Brain Foundation a few years ago on how to put into personal wellness instructional programs for her patients and families, which related to Alzheimer's and all of those. COVID hit us all and we were overcome, but I'm pleased that Cindy has gotten some funding for that. But healthy aging, and that's how Mark Clark and I have become symbiotic soulmates, because healthy aging here. And I also point out that we have a wonderful Catalina retired community who are looking for, like Dan, for ways to give back. And my role model was at St. Philip's Church. I ran into Jay Sweet, the retired CEO of Northern Trust. And I said, Jay, what are you doing in Tucson? And he said, well, I'm retired, but I'm doing early literacy work at Fort Lowell Elementary, and you should try it. It's a wonderful thing. So if we can all recruit older people in the Catalinas to give back and help the young people and mentor them and provide encouragement and inspiration. At St. Philip's, we had an after-school program, but it was hard because in low-income families, they don't have transportation. You know, life is very complicated when you're in the lower social economic. You want the best for your children, but it's, you know, there's so many things. That's all I have to say. Thank you.
Thank you, Conrad. I really appreciate that. And I appreciate the responses from everybody. My next question is going to be, and we have people represented from many industries. We've got K through 12, we've got behavioral health centers, we've got nonprofits. So I want to ask my next question in this way. And I think I want to start with, and do you like being called Dan or Dr. Ranieri? Just want to clear that up first.
Dan, please.
All right. So Dan, I'm going to start with you, and then I'm going to go with probably Tomas and Mark, and then we're going to, and then I think Conrad and Beth can bring the rear on this particular question.
I think we can call him Dan now. So
Don Dan. So Dan, do you feel there's a correlation between healthcare workforce shortages and pathways to mental wellness? If so, can you expand on that?
Well, I mean, yeah, I mean, there is. We have a tremendous shortage of people working in healthcare in general, and behavioral healthcare in particular, and not just in Arizona, but it's a national phenomenon.
Sure.
In every phase, and there's lots of reasons for that. I think the reimbursement system, the way it's set up, exacerbates that problem substantially. And in the bottom line is, the fewer people you have to provide the service is going to make it more difficult for the end user. And on top of that, the lower the skill level you have in the people providing the services is going to impact the quality of the services that are being provided. And we have issues in both areas. And I can expand on that. I think I'll hold off until people ask questions to see if there's interest in it. But there's reasons why that is, obstacles to solving it, potential solutions, and major obstacles for all of those potential solutions. I'll leave it at that.
Thank you, Dan. And I see Tomas, you took your mute off, so please enter.
Yeah, certainly. I think, for those here around this virtual table and that have joined us for this session, no surprise that we certainly are experiencing a workforce shortage, high turnover rates, lack of diversity in the healthcare delivery system. And so, we do have to be more proactive in terms of, as Dan mentioned, what some of those solutions are going to be to address those issues, especially, coming out of the pandemic. I think the pandemic complicated things and exacerbated the situation. But we do need more proactive strategies, and we do to continue to evolve, innovative clinical and payment models to make sure that providers that hire and employ our healthcare providers, have the sustainable resources for them to build the workforce and to retain employees, and all of that leading to, more consistent, high quality, culturally competent care for people. And so, I think, just kind of from lived experience, because I had loved ones that are challenged with mental health issues, and who receive services in some cases through the regional behavioral health regional behavioral health authority. And I see the turnover of, and thank you for putting that up. This is my aunt here. Unfortunately, this was the last photo I took with her, and she was challenged with mental illness throughout her lifetime. And so we had to deal with all kinds of inconsistencies with case managers, right? The high turnover and lack of access to the therapy and counseling that was needed, as well as engagement of the caregivers, family members who are allies to helping people not become so isolated and lonely. So there's a whole host of complex issues that are contributing to the workforce shortage, the turnover, some things that we're doing at the Equality Health Foundation as a solution, and I did when I was running People of Color Network, is create this scholarship collaborative with a bunch of organizations to make sure that we remove those financial barriers for diverse individuals going into the healthcare field, to the behavioral health or other parts of the healthcare delivery system. And so, that's going to be an area that we have to come together with, in alliance with others across the state to remove those financial barriers and create that interest in the next generation of students to become interested in the healthcare field and to the behavioral health space. But yeah, thanks for putting up the picture of my aunt. She was my inspiration for me getting into this field. I was her advocate, as well as my cousin, her daughter. Something that, we'll always continue to have to address is the cultural stigma and the stigma in society of people with mental illness. And that was a decision that I made when I read her eulogy in the celebration of life ceremony a couple of weeks ago in Tucson, was that we decided we were going to address this issue of mental illness in what I had to say about my aunt head on, and speak to family members, loved ones, and people that were there. Anyways, I kind of went off on a tangent, but she threw up the picture. It's real personal to me, and as it is for everyone, Mark and Dan and others, you have your own personal stories. We don't have to look too far than our neighbor, our family member, our coworker, to know someone that has struggled with mental illness, and why this is important, why we need to lean into this issue of building a more diverse, sustainable workforce in Arizona to address this crisis. Thank you.
Thank you, Tomas. And before you, I see Mark, I see you're ready to go, but before you respond, I kind of want to not reframe the question, but kind of what inspired it. And it was actually Beth, so I had met Beth. I've known Beth for years, but we met back last fall and we talked exactly about this. So I want to frame it in this way, Mark, and then of course, Beth, you can answer it as well. When you have a choice between a, entry level, let's just say caregiving, it could be about, I don't know, 16, 17, maybe $19, but then you've got in and out offering the same wage. And one is a very stressful job, meaning the caregiving, versus one that isn't. So I guess that's kind of where I'm also leading with this question. Not only is there a correlation, but those are some of the choices that some of our population, our entry-level workers are facing, and then they're making choices based on what they're viewing as less stressful. So that's kind of like, I just wanted to reframe that a little bit for you, Mark. So please answer the question any way you want. And then Beth, please jump in after.
Well, certainly. And, we know that at PCOA, and actually the aging space all around the country knows the direct care challenges. It really is a huge problem for us. And one so significant that back in April of 2020, we actually acquired the Longtime Caregiver Training Institute, which was kind of the leading nonprofit training provider for certified caregivers, the higher level caregivers that tend to work in institutions, and for CNAs and assisted living managers. So we absolutely know that, and we did that because we believe, and there's pretty good research to bear this out, that part of what we need to tell people who are thinking about getting involved in direct care working, and direct care workers, as you identified, Frank, tend to be low wage, although the wages certainly are several dollars more an hour than they were 2 years ago, and are continuing to increase. In addition to all the providers that we fund, and we fund 16 providers and own our own direct care work company, are also providing a whole host of other kind of incentives. But we know that that in order to get them in the door, we need to talk with them about their career pathway. And I'm pretty sure Beth, JTED does this at all, talk about the career pathway going forward. So that is really, really, really important. And so we continue to do that. I want to come back around just for a second, and I know time is limited, just to talk, actually, normally I talk about the direct care work industry because it's such a huge issue for people to be able to age in space. But more and more, we are hearing from people, older adults, who are calling us up and saying, I need to talk to somebody. I need to see a counselor. And unfortunately, my profession and Dan's profession, professional social workers and clinical psychologists, have done an amazing job of maintaining the franchise of being able to bill Medicare for behavioral health services. Those are the only, so you have to be a licensed independent social worker, the highest level credential for social workers, or you have to be a clinical psychologist in order to be able to bill Medicare for those kind of services. And frankly, it's virtually impossible to find those kind of people, those credentialed people who will actually bill Medicare, because the reimbursement rates for Medicare are so low. And so, which really causes people, and virtually all older adults are getting their health care in the Medicare system, whether it's plain old vanilla Medicare or the Advantage Plan Medicare. And so trying to figure out how they're going to be able to come out of pocket and pay what could be a couple of $100 an hour, $150 an hour for the hourly, to see a psychologist or a social worker or a counselor, a professional counselor. Those are huge issues, and ones that I'm not quite clear how we're going to resolve. It looks like Dan may have a more.
Yeah, if I could just jump in here for a second, Frank. So, I mean, what Mark has described is a very accurate and critical problem. Most licensed clinical social workers and licensed clinical psychologists don't take Medicare clients because the reimbursement rates are so low. At least that's true on the psychologist side. But in any event, starting back in October 1st, and some of you already know this, there is now a 988 line, a national 988 line, which is for behavioral health crisis. Crisis is in the eye of the beholder. So, you know, anybody can call in at any time with any type of behavioral health issue and have a live body, generally somebody who is a trained therapist on the other end of the phone, who will talk to them as much as they want or need. The system is fairly new. Not enough people know about it. It's easy to use. For people who would prefer, there's a text or chat component to it as well. One of our companies is probably one of the 5 largest 988 text and chat providers in the country. So we're set up to do this, and that's really underutilized at the moment. It's free service available to anybody 24/7. And that's one thing that I would encourage people to take advantage of. For veterans, they have a separate one. They can use either one. It all goes through the same system. So that's a potential solution that wasn't there a year ago for anybody and everybody to take advantage of. And they have the ability to refer you to further services with a provider in the area where you live as well.
Thank you, Dan. So Beth, please, jump in, and Dan, I'm not faulting you for jumping ahead. I'm faulting you for jumping ahead, but no, I'm glad you're starting to offer solutions, because that will be the next set of questions. But Beth, go ahead, please give us your thoughts.
So, we call it healthcare's greatest resignation that is occurring. And it's not just due to the pandemic, but it's due to the aging workforce. A lot of my nursing friends were at the end of the baby boomers, and I kept very close in touch with my girls that were practicing in industry at the time of the pandemic, to really understand what they were going through emotionally and socially, with what even the hospital was trying to do. I mean, they were all learning, how do we care for these patients? How serious is this? And now we're finding that some of these healthcare workers are having other illnesses that could be related to what has happened during the pandemic and during COVID. So, 30% of our healthcare workforce is saying, I'm going to check out, and 60% it has affected them mentally. And so, how do we work with people that we know are going to leave the workforce? So that's kind of where JTED comes in. So during the pandemic, I was still working, and I was still meeting with people. I was meeting with my community partners, and we did find a huge gap in public health and mental social health. And at that time, I had people coming to me and saying, Beth, what can we do at JTED? And because I have such an incredible administrative team, they always say, Beth, do Beth. And so I did. And so I began researching, talking to people. We are the first high school program that has been recognized for our community health worker program. This is a program that is so vital in the Southwest. These are promotores. They go out, they help rural communities. It has even come to the point where I'm beginning my conversations with Banner, who are going to use somewhat of a community health person who will be like that case manager. So there'll be a conduit from the physician to home, and this individual will be that individual, this community health person will be the advocate for the individual going home with whatever diagnosis they may have. It could be diabetes, it could be heart disease, it could be they might have some mental health issues. There needs to be follow-up, what community resources are out there. So we began our training this year. Our biggest problem is getting students to understand these incredible opportunities in many of the pathways we do have. So how do we as a community educate our youth to know that these opportunities are available and get them in seat, get their butts in our seats? We charge no tuition. They're leaving with multiple certifications. They're ready for employment. And so I have really dug deep in working with many, many different employers throughout the community, educational resources to get more information out to the community, to our young people, to get them in our doors so that we can teach them. The other program through the focus groups that we had last year, because we are building a new health high school, we are going to break ground like any day now. It's going to be at Park and I-10. It's going to be the second building of the bridges. And next year, we are going to start a mental social health program. This came out of our focus groups that I had with our community, both the community, the public, the educational community, the health community, that we all came to the table. We discussed what would be best for our young people, and young people spoke. So next year we will have, at this point, we have enough for 5 classes of kids signed up. We need more kids signed up in community health, however. Now these kind of marry. So I will be having a special session for these students who we will not be at. We can't take everybody. We just don't have enough. We have one teacher, right? So some of those kids hopefully will triage over into the community health program. So that's what we are doing as JTED, is we listen to what the need is in our community. And then I try my best to then, one of my strengths is building programs. So get those programs going, get them recognized, get them certified, and get it ready for students to learn. So that's kind of what we as JTED are doing.
Thank you, Beth. And Conrad, is there anything you'd like to add?
Yes, I'd like to pick up on Mark Clark's and Beth's on terms of, so we've had a caregiving Taylor Circle of Friends here, and we're the training site and we're the beneficiaries both. And there's about 24 caregivers to our system, but the turnover is about 30% a year for sure. But and we have everything from, we've had some high school students, and I've been impressed with their capabilities, even though they lack some maturity. The one thing I wanted to mention is one of my caregivers said, this has worked well with me, but I suddenly got above, I was on Access or whatever it was, all of these, so, a mother with small children and so forth. She said, as soon as I started caregiving, I got above the threshold and I lost my safety net. So I'm about where I was before I started caregiving. So there's all sorts of complex issues that come up. Each person is so individual. I've been enjoying meeting a variety of people in this field. Thank you.
Thank you, Conrad. And I think that's exactly kind of what might have been Dan, I can't remember who said it, but was talking exactly about that benefit cliff. You start making a certain dollar amount, and then you suddenly are unable to kind of meet your other needs. I can't remember who said it, but it was basically changing legislation to ensure that we're able to do all of those things. Okay, so I'm actually going to skip my third question if y'all had it ahead of time. I'm going right into the fourth one because I really want to come into the solutions component. And I don't want to limit it to the question that I have here. I had written how might digital and emerging technologies help to manage the crisis. Essentially, what is the roadmap to wellness? And I would love to know what you're doing in your areas, but please, it does not have to be limited to digital and emerging technologies, however way you're doing that. And again, anybody can start this part.
I'll go because that's one of the big things we're doing. Frank, I don't know if you're able to share my PowerPoint, but
Oh, yes, I am. Well, I'm going to go ahead and do that now.
yeah, if you can get to the augmented reality with HoloLens, so I can show that video. I'll preface it by saying is how do you get students engaged in their future? And it's challenging. Our kids are so technologically savvy, but they're not. I have to tell you. There are some things they just cannot do, like send an email, or, how do you appropriately open a conversation? Very basic life skills that they don't have, but we still have to meet them where they're at. So one of the things that I started researching, because this is in our hospitals and in our educational institutions, is bringing in mid to high fidelity mannequins that can help us teach students about anatomy and physiology in a very safe environment and be able to problem solve health issues, again, in a safe environment versus doing it on real peeps. So this is CAE, this is Aries. He's an augmented reality mannequin, and we currently have them at 2 campuses. A third one will be introduced, and we're also bringing in high fidelity CPR mannequins next year, which I'm very excited about, but I'm going to go ahead and let Frank go ahead and show this incredible video of what your future employees are learning.
All right, so I have my fingers crossed, Beth. Hopefully the audio will work. So let's see.
I downloaded it directly. It should directly work.
Can you hear it?
I can hear something, but the video's not moving.
Can you see this now?
Music is very pleasant.
So if you see the heart glowing, just touch it for me, and you'll see the vasculature coming up.
Oh my goodness.
It's not playing though. We can
It's
hear
not
it.
playing?
It's
Can you
not
tell me
playing.
what you see?
I'm seeing the entire
It's playing on my end.
the arteries,
Yeah.
cardiac arteries. I want all my students to see this.
Let me try a different method. So give me 1 second.
Yeah, you should be able just to open the slide and hit the arrow.
Yeah, I think it flipped to a different screen once I opened it. So give me
Oh.
1 sec.
Okay. So what you're going to see is the students have HoloLenses.
Okay,
Which
give me
allow-
1 second. Give me 1 second, Beth. I know I can pop it up. So just give me 1 second. I just got to move it to a new screen. Here we are. Okay, share.
We're the
screen.
first high school to be implementing this. So it's pretty exciting.
Okay, it should work now. So please let me know if it is. Give me a thumbs up, Beth. if
Yep,
it did.
you're good. You're good, Frank.
So if you see the heart glowing, just touch it for me, and you'll see the vasculature coming up.
Oh my goodness.
Can you tell me what you see?
I'm seeing the entire the arteries,
Yeah.
cardiac arteries. I want all my students to see this.
With most of our other stuff, it's almost two-dimensional, where it's a picture or some type of sound, and it's not all continuously together. And this is three-dimensional, almost four-dimensional in the sense of interaction.
Oh my
You can look
goodness.
through the
'Cause if you're
valves
looking,
as it's beating.
isn't that just
really cool?
amazing? The heart is right there beating in front of me.
Yeah.
Oh my goodness.
We can see the EKG in front of us while the heart is beating.
And then recommend me to do anti-arrhythmic.
Flow and the vessels will be at the same speed of if the patient is tachy or
Exactly.
brady.
When this was totally acute, the speed in which the fluid was circulating was in a more rapid state than now when they seem to be a little bit more stabilized after nitroglycerin and fluid administration. Oh my goodness. As an educator, this is the next level.
Thank you, Frank. Anybody have any questions about what we're doing in our classrooms? That's what we're doing.
That's really cool. I gotta kick that out. Okay. All right, Tomas.
Yeah, this excellent. Congratulations. This is fantastic. I mean, talking about building interest, engaging young people, and building that diverse pipeline. These are the kinds of creative, innovative solutions we have to continue to evolve across Arizona. So congratulations and thank you for leading the charge on that. And while we build that pipeline and engagement and getting more diverse students interested in the healthcare field, interested in behavioral health, and earning their degrees and joining that that workforce. One way to address the shortage and the turnover right now is through digital health solutions. So we saw that there was a tremendous uptick in accessing behavioral health services through digital health solutions throughout the pandemic. And so new data shows that that the share of behavioral health services delivered via telehealth rose from 1% in 2019 to 33% in 2022. The rates of virtual prescribing also reaching new heights as well. But as the demand for behavioral health services increased, especially as the result of the pandemic, in terms of depression, anxiety, and other conditions, we're not seeing investments and reimbursements keeping pace with that. And Dan and Mark alluded to that. So we do have to find, as we continue to innovate clinical models in terms of treating the whole person, integrated physical health care, and other social support, we really have to double down and work on reimbursement solutions, payment solutions. We can't continue to lag behind all this innovation that organizations are investing in, private equity is investing in, equal charity is investing in, without there being sustainable reimbursement models, by either whether it's Medicaid, Medicare, or commercial plans. We really have to push hard on finding those payment solution models.
And Tomas, just really quick, how just to follow up to that, how are you looking at through policy changes, like state policy changes, or?
Yeah, we really, there's multiple levels, right? Part of it is preparing and enabling behavioral health organizations to operate in this new world of value-based care, right? Paying for value versus fee for service or volume, right? Hard to do when your reimbursement doesn't support that. So at a Medicare, Medicaid, Medicare federal level, which is the largest health insurer in the country, we really have to push for more robust reimbursement of behavioral health services and complementary non-medical support, that falls in that, as Mark said, social driver bucket, right? Social determinants of health bucket, right? That 80% of what impacts your health and my health is not coverage and care. It's the social determinants of health or social drivers of health. And so we have to continue to evolve at a policy level, and at a performance-based contract level with health plans, carving out those standard performance metrics and changing the reimbursement models for healthcare providers. So it's going to be real tough for organizations like La Frontera and others to continue to build out and compensate the next generation of healthcare providers and retain them and earn a living and not have to compete with Starbucks and other places that are paying people more money to do those jobs, instead of these purpose-driven career where you can make a nice living and earn a nice living. So yeah, I think there's multiple levels of work that has to be done around this payment, at the provider level, health plan level, and the federal level.
Thank you, Tomas.
And even state level in terms of Medicaid reimbursement as well. I know we've tried to do the targeted investment program in Arizona to try to reimburse and incentivize providers to integrate physical and behavioral health care. And there was additional funding, for those that were able to meet those, those requirements there.
So
Thank you.
I think I'll be the turd in the punch bowl.
I thought that was my role.
Yeah, because what Tomas has said is true. When I went into administration, my whole job is been trying to take financial integrity and clinical integrity and put them together into a final product. When you work in the public sector, then you have to bring clinical integrity and financial integrity into a politically based system, which is really difficult because the politics is awful. When you work in healthcare, everything is driven by reimbursement model. Everything. And the only reason we had an uptick in telehealth services, which would be video services and in the phone piece, is because there was a national crisis and we were able to bill full service. Otherwise, we would have closed our doors. The other piece of this is, you hear this nonsense about value-based payments. Very little of what we do is value-based. And it's such a little amount that we really don't even pay that much attention to it. Because if we did, it would end up costing us more money to get the money than the actual money itself. The managed care companies, most of healthcare now is controlled by publicly traded for-profit companies. They don't take a long-term solution. They're looking to maximize their quarterly earnings. And everything that's done in this system is driven by that. We're paid fee for service, which basically means the more widgets or units of service we provide, the more revenue we bring in. Somebody with a high school degree, a bachelor's degree, or an unlicensed master's level therapist all bill at the same rate. So if they're billing at the same rate, why are you going to spend more money to hire people with master's degrees? Because you're not increasing your revenue, you're increasing your expenses. There are lots of digital solutions. There's apps, there's various things that we could use. I'll give you an example. Long-term care, which some of us will need, and some of us will be fortunate enough not to need it, is expensive. Why? Because basically you're looking at a human being coming in and spending a sizable portion of each day with you, which costs a lot of money. Altex, which is the long-term care plan for Medicaid in Arizona. Altex won't accept people because they just don't have the funding for more people. I've been told by a person doing the assessment, if they can dress themselves and put bread in a toaster, they don't qualify. However, there's technology that you can put in a house or an apartment that can monitor whether people are eating, bathing, taking their medication, how much they're sleeping, whether they're upright or not. And it's not that expensive, but nobody will pay for it. If somebody paid for that in advance, then you don't need people there as much, and you engage people whenever you get alerts that intervention is needed. But nobody pays for it because they're not interested in prevention. They're interested in short-term intervention and generating a revenue. You know, our profit margins usually run 2 to 3%. That doesn't give us a whole lot of leeway. For people who provide outpatient behavioral health services, when you get paid for fee for service, they need to generate roughly 3 times their income, their base salary to cover their costs. And a lot of folks won't do that, and they would rather go work somebody else where they can earn $1 or $2 more. We got money from the feds through Access to do staff recruitment and retention. So many of us did retention bonuses and sign-on bonuses. People will come, they'll stay as long as they need to get their bonus. They'll leave and they'll go to another organization to get another sign-on bonus. So there's solutions to this, but the whole compensation and reimbursement model is so screwed up. It doesn't incentivize innovation. It doesn't incentivize finding efficiencies. It really doesn't incentivize quality. And that's the issue. So unless you had a healthcare system that looks at long-term care for people over time, both from a financial perspective and a quality perspective, you're not going to get the changes that you need. Ultimately, that's going to result in some form of universal health care. It's not going to happen without it. And I think from a policy standpoint, that's where we need to go. The technologies are there, the solutions are there, all those things are there. The people aren't. We can't just expect to be hiring more and more employees, because a lot of the younger folks just don't go into this with the values that we were raised with. It's a whole different world, and there's not as many of them.
And well, I think you hit on the systems, like the system needs to change. So that needs to look different. Thank you, Dan, for sharing. And Mark, before you step in, I just want to let the group know that Beth, in the spirit of what we're talking about in regards to caregiving, she did have to step out. She's got a doctor's appointment with her mother. And so she's taking her mother to that appointment. So Mark, please, your words as well.
Well, so sometimes I feel a little Ludditic. I feel like a little bit of a Luddite since Dan talks about turds and punch bowls. Because certainly in our space, there are a lot of technological solutions. I remember even before the pandemic, the company that was started selling, mechanical cats and dogs that would bark and turn over and, do all sorts of stuff. And frankly, I know a number of AAAs around the country that bought those, especially with pandemic dollars. But the reality is Mrs. McGillicuddy needs somebody to come into her house and give her a bath. And I don't know about anybody else around here, but I'm pretty sure that my 94-year-old father-in-law, who died in March of 2020, would not really have been very excited about a robotic bath aid. Now, the good news is that, at least from our training standpoint, more of the people coming into the business we're doing are not high school students. They are middle-aged men and women who really probably took care of a family member, had some informal caregiving experience, and discovered that they liked that work. And so they really want to do the work. And those are the kind of people that we're focusing on. And those are the kind of people that will continue to build out. Now, we obviously need to train younger people. We need to do a whole host of other things. But there is a different population that I think a lot of us tend to talk about. The other, from a policy standpoint, frankly, the other policy issue, which would make a huge difference, is if we had a decent immigration policy in this country that allowed people who want to come here and make a new life and work to do so.
Yes.
So those are the kind of people who have been delivering this kind of service to people in this country for as long as this country has existed. And so, that's just, all the other policies we knew, everything Dan said and everything Tomas has said, absolutely right on about the reimbursement system. But,
right, Mark.
But if we're going to keep people in their homes, we do need to increase dollars. We need to reduce the barriers. So somebody wants to come in and do a direct care workforce job, which probably is paying somewhere in the 16, as one of you said, 16 to, I think Frank, $16 to $19 an hour, and 19's on the way high end right now. It costs them about $400 to become job ready for a job that only has about 25 hours of training involved in it. just because of all the certifications and background checks and first aid CPR and the other stuff. So trying to reduce those barriers to get people in the door is a major, and we're doing some work with the United Way here in Tucson and Southern Arizona to do that. So, I mean, there are a lot of things. Technology, the kind of monitoring stuff that Dan said, I mean, in the Area Agency on Aging, we operate an in-home support system. We have about 1,300 people that are enrolled in that system. But we're only authorizing people to go into people's houses maybe 8 to 10 hours a week. If they had monitoring services, that would probably be a better package to put together. And we do pay for some lifeline falls prevention kind of related services, but there are other technologies out there. So if this was an easy problem to solve, we wouldn't be sitting here talking about it, because Dan, Conrad, and Tomas, and Lucy Howell, and all sorts of other people would have already figured out how to do that. But it is definitely one that we need to continue to work on. And thank you all, not to wrap things up here, but thank you.
Well, thank you, Mark. And Conrad, I do want to give you space. And just so everybody knows, you got 10 minutes. Likely, of course, as it always happens, a really rich discussion. Probably don't have any time for questions. But what I would want to say is that if you do have questions or anything burning, put it in the chat box. This is being recorded. Eagles will look at it later, and we can absolutely direct any of your questions to any of our panelists at a later time. So if you do have questions, just enter them in the chat box. But Conrad, please, you have a couple of minutes, and then I want to leave about 5 minutes for Eagles for closing remarks.
Well, I just want to say that Mark and Dan and Beth and all of you, Leon, are soulmates in this quest. And I also like to mention that civilization has progressed by collaborative effort to deal with these challenges. I mean, the civilization we have today is nothing like Roman times or prehistoric times. So we can solve these problems. It's just that we need the energy, which at age 80 I don't have as much of, but we need the energy, and we can solve them if we all stand up to do it. Just like my wife's antecedents fought for women's rights. It looked impossible. So this looks impossible, but we'll do it. Thank you all.
Thank you, Conrad. So Eagles, I think we can finish with your closing remarks. Well, actually, before we do that, I know if you can do maybe hit that little reaction button for the applause, but let's give an applause to our 5 panelists, even though one's no longer here, but Dan, Conrad, Tomas, Mark, much appreciation to have you and be a part of this conversation.
Okay, great. All right, Frank, am I unmuted?
You are, sir.
Okay, great. Well, listen, let me throw in my thanks as well. I've had a wonderful time working with Conrad, piecing together this alliance that started last year and is on its way to do, I think, some great things. I have 4 important takeaways that I've gotten from this conversation. The first is the importance of collaboration. Secondly, the importance of advocacy, policy advocacy. Thirdly, the importance of innovation, and finally, funding and money, financial model. So regarding the collaboration, this kind of conversation really has to be continued across the entire behavioral health ecosystem, not only of Southern Arizona, the whole state, as well as the country. We have to understand how the whole system is working. And this kind of conversation helps reveal all the constituent parts that are part of helping people live better lives. We have payers, we have behavioral health trainers, we've got educators, we've got nonprofits, we have behavioral health providers, on and on, state government, federal government, and agencies and so forth, foundations and philanthropy. To the degree that we have a deeper understanding of all these complex interactions, a couple of things start happening. One, we have a bigger landscape for problem solving. And secondly, a bigger range of innovation opportunities. The kinds of innovations that are called for in this conversation are not innovations that are bolted to a single organization. They're really system-wide solutions. So the workforce problem can't be solved by one institution. The problem of social determinants or social drivers of health is not contained within the agenda or the mission of a single organization. The problem of utilizing new technology, digital technologies in the home, personal wellness and lifestyle technologies, artificial intelligence, data analytics, that's not a solution that one single organization can provide. So the idea of collaborative action around innovation is absolutely important, and why this kind of conversation has to be continued. It can't be a one-off just like today. Secondly, regarding policy, I think we've all recognized that there are a lot of policy issues at the federal and state level that have a big impact on how the behavioral system works. I kind of buy into what Dan's saying. The system is broken. The reimbursement, short-term finance system, fee for service, is not the way forward for the behavioral health system. And we're going to have to work collectively in order to shape policy choices that move us in a different direction. Our alliance has put together a policy agenda. You can go to our website that we got a lot of feedback from about 70 folks across the state. And so we plan to be active in communicating with the governor, the congressional delegation, and the key agencies. Finally, regarding getting money. So I think that it's by working together and building new kinds of partnerships and collaborations, we have an opportunity to essentially be much more competitive for federal funds to come out of NIH, Mental Health Administration, and so on. I mean, you probably know that earmarks are back on the table at the federal level. I think JTED is benefiting from one of these, they call them community, I think, support grants, something like that. It's really not a return to the good old days where everything was done.
I should mention that comes from Cisco Mani's office. We're very grateful for it.
Yeah, absolutely. Anyway, the point I want to say is back in the old days when I worked with the congressional delegation from Illinois, it was all done behind closed doors in middle of the night and last minute appropriation markups with the chairman and all that. And no one really knew what the hell was going on with these earmarks. Today, it's a very open and transparent process. The proposals that are put in are transparent. They need to have stakeholder support, and there needs to be bipartisan support. To the degree that we can come up with some terrific projects working with the Arizona delegation, we can end up getting a heck of a lot of money. I would say in the millions. I wouldn't be so bold to say $1 billion, but we could get millions of dollars through this process if we work together. So what's the bottom line? We need to continue the conversation. We need to have a much bigger landscape for innovation and problem solving. We need to influence policy. And we should work together on trying to get the funding and the resources that we need for our projects and innovation. So I'm very excited about what we've got going here. Please go to our website, take a look at what we're doing, register. We obviously are also interested in gaining more financial support from the community. So thank you so much for being part of this. Thank you, Frank, and the Tucson Metro Chamber for lending your time to this program. It's terrific. And thanks to all the other organizations that have participated as an audience. So thanks again. We hope to see you again and have a great day.
I'm going to